technology is probably the most critical component of being able to transform your care delivery model. And if you, as a clinical leader or a clinical operator, do not have a core competency in technology, you better be damn well sure that you have a really good person who can see the vision of how they're going to do that. I think there's going to be almost like this emerging new type of clinician. I don't know if it's
Yes,
clinical
that's coming.
engineers. I don't know where it's like a merger of clinician and engineering kind of together. The other thing I wanted to point out, and I think this is another thing that people don't realize, 20% of our medication titrations are down titrations or deprescribing.
Welcome to a new episode. Today, we are shifting gears and we are going to a space that has been different and we haven't covered so far. We have a special guest and a special company. We're going to talk about the importance of continuous care and not episodic care like we do right now. Patients between visits are not monitored, are not seen, and that's where most complications happens. So we have a special guest. Abby, welcome to the show.
Thank you for having me. I'm excited to be here.
Awesome, me too. Let's start. Can you give us a bit of an arc about your career?
Yeah, so I'm Abby Cunningham. I'm the Chief Medical Officer of Cadence, which we're going to talk about in a little bit. But my background is I'm an OB-GYN physician by training. And I spent the last 20 years working in some of the largest health systems in the country, non-for-profit. CommonSpirit, it was CHI at the time, but now CommonSpirit. I spent about 9 years of my career there. And then the last 8+ years at Providence. And I did my training at Kaiser Permanente. So kind of like the big three, I kind of spent a lot of time in those big three health systems. And I kind of grew up rising through the ranks of physician leadership. So I was leading physician groups at both CHI CommonSpirit, and then eventually moved over to Providence to be a chief medical officer of one of the large multi-specialty medical groups. So really kind of cut my teeth in physician leadership and multidisciplinary, multi-specialty medical group leadership. And during COVID, started to get a little bit frustrated with just the experience that the clinicians were having on the front lines. I was their CMO and I was trying to be their cheerleader and help through the process. But I also knew that technology could significantly improve their frontline experience. There wasn't the right people at the table helping to guide better decision-making and workflow mapping and integration opportunities to improve that experience. So I worked my way over first to corporate development team there, and then eventually took over the whole virtual care and digital health portfolio of work, which included inpatient telehealth, virtual nursing, hospital at home, remote patient monitoring, which we're going to talk about. I was also developing some clinical decision support tools as well. And then that was when I met the CEO of Cadence, Chris Alchek. He was just getting the company started. And his whole thesis was that, we have to deliver more care in the home, remotely, in between patient visits in order to better manage chronic diseases and support the aging Medicare patient population that's growing rapidly to age friendly and healthily in their homes. And I brought Cadence into Providence as I was on the other side, on the partner side, and we selected Cadence to be our remote patient monitoring partner, brought them into Providence, started to scale them in Providence over the next couple of years. And then eventually, when it was time for me to think about what my next thing was going to be, it was a natural fit for me to come over and join Cadence as their chief medical officer. I joined them in February as their CMO, having an absolute ball. It's been very interesting to transition from big health systems, executive roles in a big health system to a fairly mature startup, but a startup, and really enjoying the work. We have over 70,000 patients that we're monitoring today. We have over 20 health systems that we're partnered with, and we can talk a little bit more about the model, but it's been a really exciting journey and a very exciting company that has a mission that I deeply believe in and believe is very important for the infrastructure of healthcare in general.
I love it. Before switching gears, I still want to focus on you. I think one of the biggest things I hear all the time is, and actually last week I had a call from two residents who were interested about like what they're doing and they want to seek advice. For the physicians listening, how did you break into this space? How did you end up in tech? How did you end up having positions like you do today?
Yeah. I mean, it's not easy. I have to say, when I started doing it, there weren't very many physicians. We were just talking about the Vibe and the health conferences. I
Mhm.
started going to those 4 years ago, and there
Yeah,
were very few doctors, very few physicians or
yeah,
clinicians
yeah.
there. There was a lot of these tech companies that were like, we don't want the doctors because we need to be thinking how we're going to break this apart and do it in a different way. And there wasn't as much of a recognition of the value of clinicians and
Correct.
how
Completely agree
important
with you.
they are,
Yeah,
which I think there's been
completely
a
agree with you.
180 on that. I mean, we were almost dismissed when I would
Yes.
try to come to folks in the system or even outside of the system and be like, hey, I have something to offer you. It was like, no, you don't. But persistence, I would say, is one of the first things. I was really persistent. I also networked quite a bit to try to find stakeholders who would listen and give me a chance. When I first went to the corporate development team, I have to be completely honest. I went to the guy who was the head of the corporate development team and I was like, you need a doctor in your shop. And he's like, why? And I tried to explain to him, and I'm like, look, you're doing these incubations, you're going to spin out different components of departments that are going to turn into companies that are providing clinical guidance. I mean, you need a clinician. I can help you. I can support you. We had a big partnership with Microsoft. And he was like, well, maybe we'll let you. So what we negotiated was I was going to be still doing my full-time job, but I was going to be an advisor to his teams for 3 to 6 months, and they would see what I could do and if I could actually help them. And within 4 months, he's like, okay, you want a full-time job? So
Oh,
some of
wow.
it is rolling up your sleeves and proving yourself. I don't want to tell people to go out and do something for free, but I was like, let me show you how I can be helpful to you, because sometimes
Yeah,
they don't understand
completely.
and they don't understand how we can translate, right? Like and especially when we start to learn all these incredible skills that I learned when I went over to work with them, which was product development, a traditional informatics person. They have great expertise in the EMR, but they don't think in product. That's a totally different skill set, right? So
Mm-hmm.
when you're thinking about building a commercial grade product and you need a clinical expert to support that process, now there's more and more of us that have more of those skills, but there weren't even trainings for that when I was going through this. I just had to figure it out kind of on the job. And I had people who supported and mentored me in that process. So I think those are some foundational things, is just be willing to put yourself out there, show people, network like crazy. I tell people, go to conferences, you're going to meet people, see if you can get on some of these cool Slack communities where there's physicians, builders, innovators. Be active on LinkedIn and network that way. There's all kinds of fractional work or opportunities to work with different AI companies. I was just on a pitch this morning with one of the Slacks that I am a part of a community of, where they're talking about how there's going to be more clinicians involved in AI model validation and things like that, and
I think we were
opportunities.
both on the same call.
Oh, yeah, probably. Yeah. But so there's going to be a lot of opportunities, but you do have to
100%.
kind of work it. You got to hustle, you know what I mean? And not be afraid and reach out to people. And then there's also some other organizations that help connect clinicians to some of these advisory fractional opportunities. So, for example, MDisrupt is one of the companies where you can get on their platform, and then they kind of help match, it's like match.com for companies that are looking
Sounds
for
right.
experts and an expert network. And there's a couple other examples of companies they're doing similar things that are out there. So I think it's kind of a hodgepodge of all of that, is sort of how I see, being on the health system side, I started advising some of these companies. Can't get paid anything when you're in a health system usually for doing that if you're in an executive role, but you can still provide advisory support, and you learn a lot about advising
100%.
when you go through that process. So I did that with a couple companies. For me, it was very fulfilling because I knew that some of the guidance I was providing was actually translating to them making changes in their
Benefit.
product or making changes in their offering that then benefits patients and clinicians and the industry. So that's kind of been how I worked my way into it. I think there's so many of us that are interested in getting into this space now
Yeah.
compared to like 5 years ago. But there's also so much more interest and need. So I think if you hustle and you work it, you can find opportunities. I do want to say, though, do not discount the importance of continuing to be clinically active, or if you're not clinically active anymore, having a lot of experience as a clinician, because it does help you a lot when you're providing advisory support to still be kind of in that game and thinking clinically and experiencing clinical work. I do feel like it is quite valuable I still practice a little bit, do
Days you
it
practice per week.
just a couple times a month is all I
Yeah,
can do now.
just
But
exactly.
I
Just
still,
keep your, that's something else I tell physicians. Just keep your wet feet so at least you understand the system and its problems. So you still have good
yes,
value because systems are changing and you don't want to completely cut your medical practice.
the EMR experience that we have today is fairly similar to what it was. In fact, I just went back to start to do a little bit of CommonSpirit to do just a tiny bit of clinical work so I can keep my clinical. I was like, hey, let's do e-consults. Let's do e-visits. Let's do the only virtual care ambulatory pilot in the entire system at Providence, launched prior to COVID. So when COVID hit, we were the subject matter experts because we were the only ones doing it. And we were doing it because I was like, virtual care is the future, even though COVID hadn't even hit yet. Nobody was really focusing on that. And it was so tricky to get reimbursed. So if you look, that's what I've always wanted to do is change the way we're doing care. We did robotics before it was a thing. We were discharging patients from the hospital on the same day after a hysterectomy before it was a thing. And so I would say that technology is a huge piece. Technology is probably the most critical component of being able to transform your care delivery model. And if you, as a clinical leader or a clinical operator, do not have a core competency in technology, you better be damn well sure that you have a really good person who can see the vision of how they're going to do that. And how they're going to start to change the way we do things or find efficiencies in the way we do things through technology. But that doesn't mean that there aren't operational, logistic, and clinical components of care that can also drive that transformation. And so all of those things in concert together is really what's going to make the difference at an industry level.
Completely agree with you. I completely agree with you. I think the other thing that resonates with me is as a clinician, most of us got really drawn to the being a physician because you make a difference in people's life in one way or another. But when you work with companies or startups and you focus on technology, the delta that you make, the benefit that you make scales. You are not only affecting one person's life, you're affecting the life of thousands of people. And that's what
Yes.
also makes this type of work different from research. I have a huge respect for researchers. I'm a researcher as well, don't get me wrong. But it's much harder to translate research to benefit in clinical practice unless you're running phase 3 clinical trials versus working with a company and bringing a product to life. The benefit and the delta that you make in people's life is on much bigger scale than your time in the clinic on one-to-one with patients directly, which is still important, don't get me wrong.
Correct. I actually think it's a combination. I think there's going to be almost like this emerging new type of clinician. I don't know if it's
Yes, that's
clinical
coming. That's coming.
engineers. I don't know where it's like a merger of clinician and engineering kind of together. There's still that need for the face-to-face. There's still, I don't think, especially when it comes to procedural medicine, surgery, delivering babies, I don't think robots are going to be doing that autonomously very soon. I mean, maybe someday, but not soon.
Actually,
The cognitive components of what we do, the cognitive work we do with our patients, there is a huge opportunity for us to amplify that and reach more patients in different ways And we're the experts, right? We live and breathe it. But if we can democratize some of that knowledge that we have, democratize the knowledge and expand this amazing expertise that we have and be able to reach patients, clinicians, peers in totally new and transformational ways. I think that's just an incredible opportunity for us. And I think that's what we're going to start to see with all the AI models and things that are developing over time.
Oh, yeah, 100% agree with you. I think the other thing I want to, before the last comment, and then we're going to switch to Cadence. One of the things is I was watching this documentary about the future of AI, and this was created several years ago before it was a thing. It's on Prime, and they go forward in time where we have lenses and smart lenses, and people are losing their jobs every week. And they have a scene where a lawyer gets dismissed because they lost their job due to an automation in AI, and then they call their friend who's a doctor who is still working in the clinic, and they show you even in the comment on that scene that even in the future, doctors are probably immune from their job being lost. Our job is going to change. I think humans are, they still need that human contact when it comes to care delivery. That's something I don't think you can maybe in the next 10, 20 years fully automate. So
Yeah.
just my opinion.
Well,
Anyway,
and you're a
yeah,
medical oncologist, right?
yeah, it's very
Yeah.
hard.
I mean, I think about a patient that I saw recently in the clinic who I delivered very sad news,
Yeah, it's hard.
and
Yeah.
was there with a family member and we had to talk through all of it. And I mean, I needed to be there, the human touch, the conversation. Now, could I have tools that help me with some of the expertise questions or things like that? Yes. But at the end of the day, that human touch in person component was really critical to the experience the patient had.
Completely agree with you. Switching gears, going to Cadence. So I think we mentioned Cadence several times. What does Cadence do? What's the vision? What's the mission?
Yeah. So Cadence is a remote patient care
Hmm.
platform. And we partner deeply with health systems to be an extension of their care delivery model to provide the infrastructure, the logistics operations, the clinical workforce, and the technology to be able to provide care in between the visits that the patients have with their regular doctor. And we do this in the form of a couple different things. We have remote patient monitoring. That's what we started with, which was specifically focused right now around congestive heart failure, diabetes, and hypertension.
Hmm.
We know that these patients with congestive heart failure, diabetes, and hypertension are not being managed optimally. It's
Hmm.
not because the primary care physicians aren't doing a good job or the cardiologists aren't doing a good job. It's just the way that the care delivery is set up to see the patient every couple of months in the office. It's just not really set up in a way to be able to fine tune the patient and get them into guideline directed care and to sort of continuously monitor the patient, make adjustments, respond to any issues that are coming up in between that care. So we started out with CHF, diabetes, and hypertension. And then we also have a new program that we started. We have chronic care management and advanced primary care management. Advanced
Hmm.
primary care management codes are codes that were just released by CMS in January, specifically designed to almost democratize chronic care management to all Medicare patients. All
Hmm.
Medicare patients with one condition, chronic condition or more, is eligible for the program. And it's a subscription model. And we basically provide wraparound care, concierge like care for those patients, 24/7 access to chat or call us. So the protocols are basically the algorithm. We
Hmm.
translate it into a technology. The patients have devices. So when we
Hmm.
enroll a patient in the program, whether it's CHF, diabetes, or hypertension, they're going to get a device. And depending on what disease state, they get different devices. So we have glucometers and scales for
Hmm.
diabetics. We have scales and blood pressure cuffs for CHF. And then we have blood pressure for the hypertension patients. The patients receive their device at their home. It gets shipped to their home. It's already configured to the patient's identity. It's cellular enabled, meaning no Bluetooth pairing, no Wi-Fi is required. All they have to do is take it out of the box, and 75% of our patients self-activate and they take their first vital sign on their own without even having a conversation with us. So
Oh,
it's very simple and straightforward. The average age of our patient population is 72. So from an equity perspective, it's really important that we meet patients where they are.
mm-hmm.
The other thing is that we do all of our communication right now with patients via SMS, text, or phone. You
Mm-hmm.
do not have to have a smartphone or even a cell phone to be in the program.
There is app in the middle.
Not yet.
Mm-hmm.
But so many of our patients are in rural and underserved areas where they don't have Wi-Fi, they don't have a lot of these gadgets and knickknacks. They're very limited. And so we try to meet patients where they are. And we started out with more of a text-based approach because we wanted to avoid the apps in the beginning. A lot of these patients struggle with two-factor authentication and passwords. I mean, I just remember when I was at Providence, we had armies of people who were dealing with password recovery, and it's so hard for some of these patients. As we've continued along in our journey, and as more patients are aging in that may have more experience with digital tools and things like that, we are in the process of developing a companion app that is almost like a care coordinator in your pocket to help you with everything that you would need, especially for our advanced primary care management patients, and to provide a more enriched experience beyond text. But what we're going to do is it's not going to be a requirement. It's going to be like, hey, patient, where are you at? We can meet you with phone calls. We can meet you with SMS. And then we also have this other thing. So it's going to become available to patients. But we've been able to successfully scale. We have, like I said, almost 70,000 patients. We've been able to successfully scale without doing app. In fact, I think apps have been, to some degree, even though they can do really cool things, they've been a little bit of a deterrent for this particular patient population from an adoption perspective. So we're now getting into more patients who can adopt an app, but for 92-year-olds with a phone and a flip phone, we have to be able to meet these patients
Where they are, 100%. Would you just call them or chat with them? Or so who initiates? I think my question is, who initiates the first trigger? Is it a person from Cadence who calls the patient and check on them? Or is it the patient who takes their vital signs and then this data gets transferred to Cadence and that will initiate the trigger?
Yeah, I didn't go into your alert question, so let me make sure I
no
answer
worries.
that. Yeah. So the patients start taking their vitals, and then we schedule regular visits with them. They have an assigned nurse practitioner and they have an assigned care coordinator, care navigator. So we do coaching conversations with the patient around lifestyle, wellness, and things like that on a regular basis. And then we're able to titrate medications and order labs and things like that, again, because of these mutually agreed upon protocols, and we can triage alerts. So as the patients, we have all this data streaming from all these patients, right? And we have different triggers for when something would rise to the occasion of being an alert. And then we have different levels of acuity of what those alerts would be. So we have an alert board that's streaming all this data in, and then we have staff ordering based on a set of variables and an algorithm to prioritize who should probably be reached out to the quickest. And then when there's an abnormal vital sign, there's an automated message that goes to the patient, asks them to recheck it. Because a lot of times, maybe the patient got off of the treadmill and then went and checked their blood pressure or something happened. And then it was just more like a in the moment thing. So we'll have them recheck. If it's still abnormal, then we'll actually do outreach to the patient. So our team will outreach to the patient, talk to the patient, find out what's going on. Sometimes it's like, oh, I forgot to take my medicine. We catch that all the time. Or, oh, I'm feeling this way. I have no symptoms, or I'm feeling these symptoms. So we'll kind of do a symptom review with the patient. If the patients are symptomatic and then we'll escalate that up to them to talk to the next level of care to see if there's potential that we need to have the patient go in, or if the patient needs an adjustment to their meds. So that's sort of where we start to triage these things. And if the patient isn't symptomatic, we base titration decisions for medications based on trends. So we want to get patients into the goal of the guideline-directed therapies, but we don't react usually to just one vital sign. It's usually vital signs over a trended period of time because that's more reliable data. As you know, blood pressures and some of these things can be labile. So we're actually getting more precision around the decision-making process for when to titrate. but we also can get in front of titration decisions. I'll give you an example. We just launched a new health system a couple of months ago. And one of the stories that I really loved was there's a patient within the first week, she was throwing over 105 or something average blood pressure, 170 over, it was pretty high.
Yeah.
And so within a week, we were able to say, okay, this is like been abnormal 4 times in the last 7 days. It's over the threshold. Let's go ahead and start and do a titration. And then with still continuing to be over. And so within 2 months, we made 3 titration decisions for this patient and got the patient into control. You're not going to be able to do 3 titration decisions on a patient in a 2-month time in the traditional care delivery model. So what we see as a result, and this is what's come out in our publications, is that we're able to get patients to goal more quickly because we're able to coach the patient along and make these little changes on behalf of our providers along the way. And then to your other question, if you look at our alert data, 99% of the alerts that come through, our team can resolve. And about 1% of the time, a half to 1% of the time, we have to escalate. What does an escalation mean? Escalation could mean, hey, FYI to the inbox of the provider to let them know this is going on with your patient. You might want to bring the patient in the next week or so to just see what's going on. Or it could be sometimes we have to send the patient to the ER or the urgent care because something more serious is going on. I can't tell you how many stories I've seen of us catching a patient with heart block that ended up with a pacemaker, a patient who was in AFib. We've caught so many patients who are in AFib or having some type of an arrhythmia. We've caught patients who are decompensating from sepsis. We've caught patients who were having chest pain and ended up getting a stent. This happens on a regular basis. And so when I say, okay, we had to escalate it, but geez, these are pretty good stories for why we escalated and we actually intervened and maybe did something life-saving for this patient. The other thing I wanted to point out, and I think this is another thing that people don't realize, 20% of our medication titrations are down titrations or deprescribing. So we're not just getting alerts for high blood pressures, we're getting alerts for low. And sometimes, one of the people they're like, well, if I keep pushing this patient to the blood pressure to be low, 130 over 80, but then I'm worried that they're going to be hypotensive or feel dizzy, we're checking on these patients daily so we can make adjustments more rapidly and get the patients into the guideline directed care, but then also be able to respond very rapidly if they're experiencing symptoms. So the patients can inbound to us anytime. They can text us or call us and say, I'm feeling dizzy or I'm not feeling right or whatever, and we can work through it with them. But we also, again, patients start to get better. They lose weight. The health coaching, we have a lot of stories of patients, I lost all this weight, I'm exercising, I'm eating better. Well, they might not need as much of their medication. So we're actually able to start
1%.
taking patients off of their meds. So that's actually really something that I think we underscore sometimes about the fact that not all of our titrations are up titrations. Many are down.
Gotcha. I think so. As a clinician, I'm so happy now. I'm listening to this and I'm relaxed. I was like, oh, wow, there is someone who will take care of my patients while I'm at home, enjoying the weekend. I'm sleeping overnight. That's amazing. But let's say I'm a CFO. I was listening to this. I was like, oh my God, that sounds really cool, but this is going to add lots of costs. I'm not sure as a hospital we can afford this. So how can people afford it? Are we going to ask the hospitals or me as a CFO, we're going to have this another expense on our balance sheet? How does the business model work?
Yeah, that's the beauty of how we partner with health systems. So the way the model works, CMS released inpatient monitoring codes that are reimbursable. So you can get reimbursed. The problem that health systems have had historically is that number one, they're not designed and set up to deliver remote patient care at scale. So they might invest a little bit of money in the technology piece and have a couple nurses trying to do this on the side while they're trying to do other things. It doesn't scale. It's very hard to get reimbursed for it because there is a certain science to ensuring that you meet all of the compliance related criteria to do it. And so we're purpose built for that. We're designed to be able to scale remote patient monitoring. And were designed also to partner very closely with the health system. We integrate very deeply into that it is a seamless experience for the clinicians on the health system side to enroll their patient. It doesn't create friction for them. And so the way our business model works is we provide the logistics, the operations, the clinical workforce, the technology, infrastructure to deliver remote patient care. And then we provide all of the documentation to the health system so that they are enabled to get reimbursed for it. And then once they get paid, they pay us, and the fees they pay us are less than what they get reimbursed for. So they actually end up with a positive margin on fee-for-service
So they're
billing.
making money through this solution and taking care of their patients.
Not making a ton of money.
But at least
most ambulatory care loses money, as you know, and then they make money because they have downstream hospital services. So most ambulatory care, if you look at the financials for health systems, most ambulatory medical groups run at a loss. We call it an investment. There's no investment that they have to make for us to be able to do this. And we're unburdening the primary care physicians in many ways by providing this in-between care. Obviously, we have to build trust to be able to feel comfortable with doing that, but we are unburdening their PCP, so it's a win. And they pencil positive from a reimbursement perspective. But the bigger piece of it, because this happened while I was still at Providence, I kept saying to the Cadence team, because I was an advisor for them at the time, I said, if you can demonstrate that we can pencil with a fee-for-service positive margin, but reduce total cost of care, that is a transformational outcome. And last year in October, Cadence did an actuarial study on about 6,000 Medicare beneficiaries.
Oh, wow. I was just going to ask you about that. So
yes,
in theory, all this sounds great, but what's the evidence behind it?
Correct. So they did an actuarial study on 6,000 Medicare beneficiaries and were able to demonstrate a average total cost of care reduction of $1,300 per beneficiary per year. Okay. And then that was largely driven by a reduction in admissions. So 27% reduction in inpatient admissions for the patient cohorts when you compared them.
Wow.
I saw that data and I was like, okay, this is a crutch for innovation for big health systems to help them start to pivot the way they deliver care, because you still need all that brick and mortar care. We don't have enough hospital beds. We don't have enough clinicians. We still need all of the infrastructure, brick and mortar that's there, but we can actually plug into the health system and then help them start to pivot towards value-based care through this program. And then the New England Journal of Medicine article that just came out 2 weeks ago that I sent you further validates that. It was a case study that we did with Providence, and it reproduced many of the results, which is that we're driving better compliance with guideline-directed medical therapy for CHF. We're improving getting patients to goal for diabetes and hypertension control. And oh, by the way, $2,400 average total cost of care saving per beneficiary per year. And if you start to package those things up and you start thinking about your Medicare shared savings programs, your ACOs, all these things where you're taking on risk with the risk-bearing entities, and we are not just adding cost by adding RPM, we are actually reducing costs by adding RPM. And we're keeping the health system solvent in the sense that we're not scraping away from precious capital dollars that those health systems need for other initiatives. We as a company are taking on the risk to get this stood up for the health system and helping them with a revenue margin positive fee for service.
It's not only numbers and white paper. We are talking about a real paper that got published in the New England Journal of Medicine. So we're going to add the link to the paper in the comments for those who are interested in reading it. This peer-reviewed, credible journal. So these numbers are real.
They did a full colonoscopy.
Exactly. I love that metaphor.
I love the New England Journal of Medicine editorial team. They're awesome and amazing humans. They definitely want to make sure that every word and number is legit.
Now, at this day and age, I can't talk two words, mentioning the third word, AI. So do you see or do you implement right now AI in the workflow?
Yeah, so it's a combination of different things. Obviously, you have to be really careful because many of these health systems, we have to make sure that as we implement and bring AI use cases into our offering, that we're respecting the governance processes and the things that they need to go through in that process as well. But we do have aspects of AI, and we are pretty bullish on continuing to evolve and have a pretty robust roadmap as we continue to push out features. But I almost think of it as a feature set that enables the care delivery. And it's not one thing, it's many different use cases that we will use to evaluate. So I'll give you a couple examples. We use AI to help us surface insights. So we have patients now who have been on the Cadence platform for 3 years, right? It's the same way with the EMR. There's so much needles and haystacks as data accumulates. So how do we make sure that we surface information that is the most valuable to the clinician? The clinician can still dig through the chart and things like that, but how do we bring up those insights and surface those insights in a more efficient manner so they can really find the things that they're looking for, or they can actually query the chart to look for things like, has this patient ever had symptoms related to this medication before I would prescribe it, that kind of a thing. And we're starting to see some of that evolve in the traditional EMRs as well, but those are some things that we use it for. We also use it for deterministic logic, but we do have a capability to also surface patients called proactive titrations, where we're actually surfacing, we're scouring the charts and looking for signals. And then based on that set of signals, we're actually surfacing patients that might benefit from a titration more quickly and when they have a regularly scheduled visit. So we started doing that in the early summer last year, and we've been able to almost 3x the number of medication titrations that we're making for patients because it's so much more efficient at finding the patients that would benefit, which is resulting in getting patients to the clinical outcome faster, right? A larger number of patients in the cohort are reaching the target and the goal because we're being more proactive about distilling down from a precision perspective and identifying the patients who would most benefit and leveraging our workforce to utilize the time that they spend with the patients that need more interventions more quickly versus patients who are in pretty good control and don't really need as much from us. So how do we think about splitting up the work in that way and leveraging AI tools to do that? The other thing that we do is personalization. So we're able to use, wouldn't it be nice when you talk to the MA or you talk to somebody in an office, maybe you've only been there one other time, they might not always remember everybody that comes through your door. If you could have some personalization brought to the surface to remind you, hey, their daughter had a wedding last month. You might want to ask about it. Little things that mean a lot to patients that show that you know them, you know who they are, you know a little bit about them. So sometimes we would put that in sticky notes and things like that in the EMR, but how do we create some personalization to support that compassionate care component? And so we have some tools for our care navigators to help them personalize those visits a little bit more. And also, how do we take the scripts and the audio conversations that we're having with the patients when they're talking about diet or exercise and their preferences, and then start to weave in suggestions based on what they say they like to do? I really like walking along the river to get my exercise and remembering to talk about that with the patient when we see them, versus trying to tell the patient to go boxing for exercise when that's not their thing to do. You know what I'm saying? So and the same thing with diet. I think we do that a lot. We're refining those recommendations as well.
I just want to add important point here. I think you mentioned it. I think we always get taught in the medical school and everywhere, always pay attention to polypharmacy because it can lead to falls and falls is hospitalization, all these things. But now after talking to you and talking about the down titration, and I want to emphasize when we say titration, also there is the down titration. There is the possibility of cutting down medications, and that's something doesn't really happen in the traditional care. It's
It
so
does
hard to
not.
down titrate medications when I'm in the hospital and someone's blood pressure is high, but their blood pressure is high because they're in the hospital. It's so hard to down titrate like Haldol when they're agitated, but they are agitated because in the hospital, right? So I think this is the new way of treating polypharmacy and decreasing the complications that happens from this. If you don't monitor patients in the outside those points we see patients in, there should be more reimbursements because that's where the money is. The money is not in the hospitalization. This is reactive healthcare. I think the money is in the house where the patient is living. How do you reach out to them? How do you prevent further complications from happening? If you spend money in the house, you're going to spend less money in the hospital. So I think that's something now after talking to each other, I was like, wow, I think this is pretty valid thing to do.
Yes, and I have to tell you, so we help with updating the med list,
Yeah.
if we're going to titrate a medication, we go into the health system EMR, and
So you
then
are linked to the health system
we do
EMR.
a
You like you did
med
this.
reconciliation. We do a lot of med reconciliations. We
Oh
do
wow. You guys
those.
have pharmacists also on the team?
No, we can do medication reconciliations.
Oh,
We
okay.
have nursing and things like nurses can do it.
Okay.
So yeah, so we reconcile meds, and I have to tell you, we specifically focus on for the remote patient monitoring on the disease specific medications. So we're not even going through the entire med list,
Mm-hmm.
just for the disease specific medications.
Mm-hmm.
30% of the time, 30% of the time, there's a discrepancy between what's in the EMR, which is supposed to be the source of truth, and what the patient says they're taking.
No, I think the 30%
30%.
is underestimation.
Well, if it was the whole med list, it would be higher. Just
Okay.
talking about the disease specific meds. And I'm thinking to myself, 30% of the time, what's listed in the EMR is not what the patient's actually taking. And then we've started breaking down the reasons, right?
Mm-hmm.
The patient didn't realize they were so many times we're catching patients where they just did not understand how they were supposed to take their medication. Or the patient had the medication changed by their provider or were told to double up or whatever, but it didn't get changed in the EMR. So that happens a lot. We have a lot of patients who have barriers, right?
Mm-hmm. Yeah.
They can't afford the medication. They forgot, don't have transportation to get it. And they don't always talk to their provider about that. So we are unearthing all of these different things. It's very fascinating. And I think to myself, you think as a physician, you prescribe something and here you go, and you can go and take it and we'll see you back in a couple of months. And what's really happening in the home is oftentimes very different from what it is that you have prescribed. And so our ability to continue to reinforce what the doctor has ordered, what the clinician has ordered for the patient, I think is a really important point, especially with aging patients. And we get a lot of feedback both from the caregivers that can be on our platform with their patients. So we have a lot of daughters, grandchildren, spouses that participate in receiving the messages from us and being part of the care delivery. And so many of the caregivers tell us, I am so grateful that we have this program. It's like a safety net and an extra layer of support for my, 82-year-old father who lives alone. And I live 45 minutes across town from him. It's such a critical aspect. And I can't underscore how important that capability is and so meaningful to so many of these patients.
100%, I agree. Now, after talking about it and thinking about it, the healthcare system I think, has to go through a radical change. Right now, we focus on treating disease. The focus should be on preventing disease. And that's something we're waking up to, which is much cheaper. And I think that's where not only primary prevention, secondary and tertiary prevention, well, you get things early, you take things early, or even you prevent overtreatment and you prevent complications, tertiary and quaternary. So I think that's the future of care. It's just the system also has to change. And I think the system has to support more what Cadence is doing, because I know you guys had published in New England, but I think there is even more you guys achieve and you can publish about. But I'm very excited to see what else you guys do.
Yeah, absolutely. We're very excited as well. And I'm super grateful for you having me on the show.
Oh, it was a blast. Thank you so much. It was a really cool conversation and it really changed how I think about some things. But thank you so much for being here today.
Thank you.